speaker?
Yes, please.
Right. So I have the extreme pleasure from Dr. Sessi, who invited me to moderate this great session among very excellent and esteemed speakers and panelists. So we're talking today on vitrectomy masterclass, and the first speaker is Dr. Steve Charles, who's a well-known vitrecal surgeon. I think it's very hard to imagine retinal surgery without the contribution of Dr. Charles over the past years. He's been very instrumental in introducing a lot of things in retina. For example, scissor segmentation, disposable cutters, medium-term PFO, together with other things. I think most of the machines and platforms that we work with today are the products of his work. So I think he would be the best person to talk about vitrectomy, past and present. So I'll leave it for Dr. Charles.
The audio is mute, Dr. Charles. You're mute.
I'm sorry.
There you go. Okay, thank you very much for allowing me to present in this manner. I'm between cases in the operating room, and I'm going to jump right into sharing my screen here, and we'll. Meanwhile, I've got the last slide instead of the first slide. Again, thank you for allowing me to participate in this symposium. The title was assigned to me, Vitrectomy Past, Present, and Future. I based this on a talk I gave at the Mockamer Memorial, and then I expanded upon it, and a talk I gave at the Kelman lecture at the ASCRS. And so if you attended ASCRS, you might have seen some of this, but the idea is to show how one step in surgery, one machine, one technology led to an improvement. What was the driver? How do we move from one method to the next, to the next, to the next? And what was the outcome measure that showed us we should move forward? So that's the idea of this talk. Anything in red is something I developed. So instead of saying me, which I think is too egotistical, I've just put it in red. So this is the very first vitrectomy machine, or a latest version of the first one, the disc that Robert Mockamer and Jean-Marie Perel, Jean-Marie's an engineer, still works at Bascom Palmer, very close friend of mine, that they developed. It's interesting that in September 70, Anton Benko, who did the fluidics for phaco, invented a very similar instrument. So there is some controversy, and the paper from Golem Payman was only a month later on another instrument. So, but instead of worrying about exactly who invented it first, it's a great idea. It's helped millions of patients worldwide, and Mockamer, to his credit, what he really did that Anton Benko didn't do, and Golem didn't do, and that is to do courses, to teach fellows, to teach numerous surgeons how to do this. So I'm a byproduct of that, and a product of that rather, and I appreciate the process. So Connor O'Malley, frankly, doesn't get enough credit. Connor O'Malley invented, along with this engineer Ralph Hintz, and we got to always acknowledge the engineer's role, developed the Accutome and developed three-port vitrectomy. So this is a 20-gauge system. These cutters were not disposable. They weighed about 22 grams. So instead of 900 grams, like the disc and the rotor extractor was up in that range. So three-port vitrectomy, axial motion, so-called guillotine cutter, not disposable. Then I developed with the late Carl Wong, a PhD, the hourglass-shaped, pneumatically driven disposable cutter, which is various versions of that are what's in use today. And that the first one we developed was, of course, 20 gauge. Then I developed the Innovit, which was the first dual actuation cutter, which eliminates the spring. And then Alcon adapted that to the Ultravit cutter, which is dual actuation guillotine cutter. What about aspiration fluidics? That also had a nice evolutionary path. Mockamer literally had a syringe operated by the assistant, which was frankly a nightmare. I developed a racket pinion syringe, which I'll show you. So at least I could hold a rotor extractor or a disc in one hand and control the vacuum with the other hand. It was better than nothing, but foot pedal controlled on-off aspiration, which is what Connor O'Malley developed, was a big advance. So your foot controls just the on-off for the vacuum. And then with the late Carl Wong, I developed linear aspiration or linear suction, which means the farther you push the pedal down, the more vacuum you get. After that, it was always improvement in the fluidics at the console level, faster and faster fluidics, smaller and smaller chambers that were self-emptying. And that's where we are with the Constellation. So this is that syringe drive I alluded to, so you can control vacuum yourself very precisely, but it tied up a hand. So again, foot pedal control economy much better. So this shows you the original Accutone with the foot pedal controlled preset vacuum. This shows you the Accutone 8000, which I developed with Cooper Vision with Carl Wong, and that had the first sidekick on the pedal, so you could turn frag and cutting on off with the pedal. So dual axis pedal, and of course it had the first linear or proportional aspiration control. And then this led to the disposable self-sharpening cutter on the MVS. I developed a system called the OCM. We used it on patients. Several other physicians used it on patients. Alcon bought the technology in 1991. That resulted in the Acris and the Constellation. Every feature that we have now, cervical control, interocular pressure, dual actuation, xenon light source, tool ID, all of those were on the OCM machine which was acquired in 1991. And so that led to the Acris. I won't go through the details. Smart keys were a big deal here. And then that led to all of this stuff in this picture, the phaco machine, the Acris, the laser, the xenon light source, all of those are replaced by the Constellation in a single system. And I'm the architect of the Acris and the Constellation. Membrane pilling. Mockamer was very brave. He did it first with a bent needle. Conor O'Malley invented the pick. Other people think it's Ron Michaels, but it's not. It was clearly Conor O'Malley that introduced the pick first. And that was the point of that, was to have a blunt instrument, not a point. And then I developed forceps membrane peeling. That evolved to the current ILM forceps depicted in the top picture, which grasp at the leading edge. And that's the point. They don't grasp like regular forceps do. They grasp right at the leading edge. So those two plates don't close together. The front closes first. And that is essential for ILM peeling. This shows you kind of how that works. I'll skip through that. Then if the membranes are more adherent, you can't peel, so you made retinal breaks. So diabetic traction attachments are not peelable for the most part. So I developed first scissor segmentation, cut membrane into segments or epicenters, and then I developed subsequent to that delamination, which means to cut in the potential space between membrane and retina. And then that led to cutter delamination, which with the modern beveled cutters and better fluidics, you can do more and more of those. For tabletop traction attachments, you still need, in my opinion, to use scissors on tabletops. So this shows you how inside-out delamination works with the scissors. What about fluid air exchange? Mockamer literally had a needle in the eye, deflated the eye, turned to stopcock, and blew it back up with gas. So you had a deflated eye with a needle in it. Bad idea. So I invented fluid air exchange and air gas exchange so that you infused air as you were aspirating fluid. And then Gary Abrams developed the iso-expansive air mixture, and Brooks McEwen at Duke brought us the continuous air pump instead of driving the syringe and air with the syringe as I did. So this shows you fluid air exchange. You're all familiar with that, and air gas exchange. And air silicone oil exchange, which developed as well, this concept of venting a port so that you always have normal intensive oil installation. Subretinal fluid. Mockamer did conventional scleral buccal-like transscleral drainage, but I developed endodrainage, drainage through the retinal break or through a drainage retinotomy. First with a straight so-called flute cannula, and then with a tapered and angulated one. And then, of course, this was improved dramatically by Conor O'Malley's invention of foot pedal controlled vacuum. Sandra Gazard and Harry Flynn independently developed basically soft tip cannulas. Harry Flynn's one was a very long one that threaded underneath the retina. And Stanley Chanling, of course, bought us perfluorocarbon, which is a huge step forward, not just for giant breaks, but for many other things, including now the retinal patch grafts that Tamara Mahmood bought us. So by progressing from single port vitrectomy, in which Mockamer and Dubas had, to the three-port vitrectomy, it enabled all these other techniques that I just described, subretinal surgery, aspirating parsplanal lensectomy. It enabled all of those because the infusion was always in place. That was a big deal. With PBR developed retinectomy, whereas Mockemer is an advocate of retinotomy. We'll discuss that briefly, and punch through retinotomy for subretinal bands, so you don't have to do like Zvoinovich and make a huge cut in the retina and flipping it upside down to remove subretinal bands. So here's forceps membrane peeling for a star fold. Here's the anterior loop traction, which is not a membrane, it's radial vitreous fibers. And here's the subretinal band being removed through a pre-existing retinal break. And here's punch through retinotomy. This is retinectomy, showing that all the tissue anterior to the circumferential cut is removed. This is reduces hypotony, neovascularization, and recurrent PBR compared to Mockemer's method of leaving all the tissue anterior to the cut. Introduced the concept interface vitrectomy, operating under air or operating under oil, and of course Stanley Chang brought us operating with PFO in the eye. All the techniques we're used to, many of which I just described, are possible under air, under oil, and under PFO. They have different characteristics, not appropriate to discuss right now. Let's skip through this in the interest of time. So can you do membrane peeling under oil? Yes. So this shows you an EMM, an epimacular membrane, with a 2-port technique under oil. Normally we use 3-port and infuse oil with a Med1 cannula when we're doing PBR re-ops, because you have to replace the volume when you aspirate subretinal fluid. So here's removing a star fold in a PBR case with oil already in the eye. I never remove oil to reoperate. It's absolutely unnecessary. I hear reports all the time, the 3 and 4 and 5 hour PBR operations. I just did a PBR case just now. It took 18 minutes. There's no excuse for these 3 and 4 and 5 hour operations. I introduced the concept over 20 years ago of leaving PFO in the eye for 2 weeks, so-called medium term. This has really great results. It's wonderful. You don't need a buckle for inferior retinal detachments or schisis-related retinal detachments. We've been very happy with this, particularly in kids with inferior detachments. And I've done well over 1,000 cases with medium-term PFO. We now use it for the macular patch graft, now called ART. I invented endophotocoagulation. It was initially xenon, and then at the same time, Jay Fetterman, myself, and Reese Landers all introduced laser endophotocoagulation. But the first endophotocoagulation was xenon, done with this adapter you see in the upper right part of the screen here that I built at the NIH, attached to the big size endophotocoagulator source. We then transitioned to this xenon source that Patrick O'Malley, Conor O'Malley's brother, developed. And then you can see the fiber delivery system in the top. And then, of course, the Constellation has an embedded thin disc laser, which is very thermally stable and produces the same output if you do 2,000 spots as if you do 1. What about the future? In the interest of time, I've just made some bullet points, but there's clearly a trend for faster cutting rates, which is all about non-pulsatile vitrectomy. The fluidics have a faster response time to your foot pedal command. The surgeon's reflex time, which is 400 milliseconds, is the slow part now. The system can respond at least twice, if not 5 times faster than the doctor. I used only the Ingenuity, the 3D visualization. I didn't invent it. I don't get a royalty on or anything, but it's the only thing I did. But head-mounted displays are a mistake. I won't go into the reasons why. There's some vertigo reasons and convergence accommodation conflict and resolution-related issues. But in short, head-mounted displays are not a good idea. But 3D visualization digital visualization is a great idea. Embryonic stem cell sources to replace outer retina are nonsense. The patients have to be immune suppressed. You can't immune suppress somebody with geographic atrophy that's 75 years old. You simply can't do that. They'll die of infectious disease. And that has in fact happened. So it has to be induced pluripotential stem cells. Permanent scaffolds cause inflammation. They don't work. Cell suspensions, think OpRegen, don't work. They don't engraft. So you have to grow RPE and photoreceptors derived from iPSCs, CD34 positive circulating cells, built in tissue culture. So it's a tissue engineering task, not a cell suspension injection task. I've heard people say someday OCT with AI will drive robots. That is ridiculous. I won't go into the reasons why, but the part of it is ambiguity, projection artifacts, obscuration artifacts. and the fact that you don't have solid geometry with OCT. It is basically taking data and assigning it on a presupposed geometry. So that whole idea in AI doesn't fix things like that. The retinal prosthesis, Argus, to it, etc., was a failed enterprise. It doesn't work, and I think there's no future for electronic retinas, bionic retinas, what are going to call them, enzymatic vitrectomy. It was tried numerous times, numerous different enzymes. It's a failed concept. Don't inject a non-specific protease in an eye that has proteins in it. Bad idea. So no future there. Artificial intelligence to read images. Everybody and their uncle talks about it at every single meeting. But have we shown that there's a shortage of image readers? Has anybody worked through the social issues and economic issues to get treatment like Avastin to the large populations of people that are poor? Who's going to do the delivery side of the treatment? Where is the emphasis on the social issues, the economic issues, transportation issues, instead of, oh, we have AI and it's going to read pictures so doctors don't have to read them? It's crazy. So thank you for letting me go through all this real quickly. I hope it was helpful.
Thank you, Dr. Professor Steve Charles. That was a very enlightening talk, and we got an insight to what the future holds for us. Any questions by the speakers and the panelists to pose to Dr. Steve Charles?
Yes, can I get a question, Dr. Sethi?
Yes, please.
I just wanted to ask, I know we're talking about vitrectomy, but wanted to get Dr. Charles' opinion on buckles. Are they going to stay, or do you think the future is not?
I've been trying to drive buckles off the planet for 2 decades now. Why? I've attended every American Society of Cataract Refractive Surgery meeting, but I don't do cataract surgery. But what have I learned? Patients actually like to be emmetropic. Patients don't like ocular surface disorders. They don't like strabismus, and they don't like pain. So modern day cataract surgery has made such a phenomenal experience for them that, people have LASIK, and then they go on to get an attachment, which of course wasn't related to LASIK. Do you want to encircle them and give them another 3 diopters or so of axial myopia? Ridiculous. Patients have an IOL. 47 formulas are used to calculate IOL power. Maybe it's femto laser assisted, et cetera. High-tech cataract surgery. The patient's emmetropic on the first post-op day. Then they get an attachment, which is 1% of all, at least 1% of all retinal, cataract surgery cases. And then you put a band around the eye and make them myopic. I heard people say, well, I did a MIVS vitrectomy and an encircling element. There's nothing MIVS, which stands for minimally invasive, about a buckle. So learn to use medium term PFO for inferior attachments. Learn to use wide-angle visualization that Ruben Belfort's invented. Learn to look at the periphery more carefully with various types of scleral oppression so that you can fix retinal attachments without having to suture a piece of silicone rubber in the eye. It's time to bury this outmoded concept that served us well for many, many years.
Thank you very much. I could not agree more. Thank you very much. Now, another question. What are your thoughts on smaller gauge vitrectomy? You think we're going to go smaller than 27, and you think it will be the future?
No, the fluidic resistance is proportional to the 4th power of the diameter. So you just have ridiculous fluidics when you're down smaller than 27. And 27 gauge wounds don't leak. The 27 gauge instruments are stiff enough. But if you go smaller than that, you're going to have more problems with instrument flex and slowed fluidics. You don't have a problem with laser or light delivery. That can go down a 30 gauge needle, but with proper numerical aperture matching. But no, I don't see a future for 29 gauge.
Thanks. Thank you very much. Dr. Sethi?
Sir, I had a question on cutting rates also. Does the existing cutting rates are enough, or do you feel they will cut off at 20,000 or the 50,000, or it be going on? Or do you think there is a future for more and more higher cutting rates, or there is a ceiling?
I apologize. I don't have a very good audio connection. I'm not following your question. I apologize. Could somebody else maybe repeat it for me quickly?
Sir, does the higher cutting rates as a ceiling, or we can go up to 50,000 or 1 lakh cut rates is what I'm asking, or the existing cutting rates are good enough?
Cutting rates, is that what you're asking me? Okay.
Yeah.
So when we hear people talk about ultrasonic vitrectomy and describe it as a megahertz cutting rate, that's a bit of a mistaken notion, because the problem with ultrasound, for example, is it produces radiative energy, that it radiates energy from the tip. So it's all about limiting far field effects and confining the effects to the region of the port. So the notion that, I won't tell you who it is, but a very famous surgeon that used ultrasonic vitrectomy. I said, what it's like? He said, it's the best retina remover I've ever tried. So we don't want to carry this to that extreme where we're radiating energy from the tip in order to claim a higher cutting rate. Now, is 20 hertz, 20,000 cycles per second, cuts per minute? I'm sorry, I'm so hyper. Is 20 better than 10K? Yeah. Is 30K better than 20K? Yeah, it is. Now, does that mean we're going to top out at 30, or maybe we'll go to 40? There might be an advantage with so-called dual blade cutters. They have an open duty cycle, so you can handle these higher cutting rates, particularly with dual actuation, where you don't have a spring return. So there's no limitation at the port to flow rates. So maybe 40K or something, but it's not going to be megahertz, and I think that probably never reach 100. I think it'll be 50K or less.
Thank you so much.
Okay, so thank you very much for allowing me to participate, and I think I'll sign off and go back and do surgery.
Thank you very much, Professor Steve Charles, for your time.
Okay, be well.
Thank you. Dr. Ashray?
Oh, yeah.